I'm delighted to introduce my UC colleague, Aenor Sawyer from the University of California, San Francisco. She is a leader in digital health innovation and the Associate Director of Strategic Relations for the Center of Digital Health Innovation and the Associate Director of Digital Health Track and the CTSI Catalyst Accelerator, also clinical advisor to Rock Health, and was a member of the Clinical Advisory Board for Hippocrates. With that, Dr. Sawyer, take it away.
Great, thank you very much. It's a real privilege and an honor to be here today, and I really appreciate this opportunity. So I'm going to talk a little bit about some same subjects, maybe a few new comments, hopefully. It's something I learned from the panel today, and I learned a lot from the panel, but one thing I learned is never go last on a panel of really smart people who have really great pictures. But I will try not to bore you. I know it's been a long morning so far. So I'd like to move on, and I'm going to talk a little bit about idea to impact and what we have now in digital health, what's next and what's needed. Sounds familiar. Some themes hopefully will be redundant because it means that we're all recognizing the same things. Hopefully a few new ways to look at it. And I'm also going to mention why I think it's important for people on the front lines of healthcare and academics to be involved in this, and why it's incredibly important that we all partner. So I won't spend much time on this because I think you've heard many of these themes, but I do want to say that there are promises out there and there are changes in healthcare delivery that we both need to respond to and we need to aim towards as well. There are a lot of forces that are pushing us to improve healthcare. Each of us on the front lines wants to improve it. Certainly all the recipients of healthcare want it improved. There are also funding opportunities and mandates, so combinations of carrots and sticks, and this model is unsustainable. And not only that, you've seen in the last presentation, it's actually not working very well. And there are also, more excitingly, many, many new technologies and tools that can help us do a much better job. Let's see. So there is this explosion of proposed disruptions enabled by technology, and I always think of healthcare solutions. Effective healthcare solutions are combinations of personnel, process, and technology. So when I talk about effective healthcare solutions, I'm always thinking of it in those terms. But we see these changes happening in clinical care, healthcare delivery, research, and across all silos. So very briefly, because this has been well defined by my colleagues here, but what is digital health? We say that it's hardware and software. We also, with the cloud now, say it's nowhere. And if you want nice overviews, go to Paul Saunier's videos. He has 2 of them now that do a really nice overview of digital health. And it's an endless spectrum, from very tangible things such as sensors and devices to the intangible ones and zeros that will hopefully eventually make them meaningful, from tiny nanoparticles up to large servers and databases. And the components are endless, as you can see here. And they range all the way from the devices we've talked about, all the way through the genomics, phenomics, and the platforms and databases, the algorithms, analytics that you'll hear more about as time goes on, because it's a spectrum that's extremely broad. And we did have really nice presentations on the mobile and the wireless components. But to make all of those things eventually have meaning and be contextualized, they've got to fit in with the other pieces of the system. And who does it serve and what does it do? It should ultimately provide wellness, health, not just personal, but also population-based health, and serve a variety of audiences and stakeholders, which is why we consider it a multidisciplinary field. And you can imagine going from idea to impact, that you have a variety of disciplines involved. And doing multidisciplinary work is both very exciting and also challenging. But it's so important for us now to consider these things rather than saying, we're over here in the tech sector, we've solved other industries, we need to come in and solve your industry. And we're in the healthcare system saying, we actually know more about this than you do. What we really need to do is bridge, and bridge not just between those 2 disciplines, but across many, which I'll outline here very briefly. So what we have to do is involve healthcare people, recipients, administrators, providers, researchers, and we also involve the tech sector, the business and investor community, design experts, which we're working very hard on bringing more design thinking up front in the process of innovation in healthcare, health policy, health economics, established organizations and corporations, and not just the big corporations, but the individual entrepreneurs. And also a very exciting thing for me in this work is it's cross-generational. And I think you'll see the themes coming in as the people who are like the med students that I work with nowadays, they're fluent in technology. They've grown up with it. It's their language. It's how they function in the world. So they're often bringing some of the best ideas forward because they've used it to solve other problems in their lives. And yet we have very established domain experts who are at the other end of the age spectrum. We also have at the other end of the age spectrum a phenomenal untapped resource of seniors who actually built the internet and can contribute back into this work that we're doing. So AARP is very active in involving them, as are we. It's a multidisciplinary world that brings both tensions and rewards. We have very different vocabularies when we sit down to work across sectors. We have different incentives and cultural tensions, such as even the metabolic rate. So I'm over at Rock Health Advising, where there's a metabolic rate of a mosquito, and everything moves really, really fast. And then I go back over to the university, and it's the metabolic rate of an elephant, and it's back and forth. But what we need to do is find some alignment in the middle, even around the pace that we do things. Another example is around security, and we hear Andy Grove, who I adore, saying free the data, and then I'm getting 5 texts or emails a week saying you could be responsible for a $250,000 fine personally if you have a PHI breach. So those are the types of things where we have these polarized tensions, and I think a field of aligned design would be really helpful in this sector where we find alignment. It may be dynamic, but we need to figure out how we pull people together into the sectors, across the sectors. And if we do that, there will be hybrid vigor. We will have ideas that would have never come from one sector alone. So looking at the digital health trends, I still think the edges are way out of sight. I think there's endless possibility, especially as we get better and better at layering the types of data that we have access to now. Clinical data, physiologic data, patient-reported outcomes, clinical research data, which there are volumes of, extended care, and also the EMS system. So just to let you know, that data sits completely out of the clinical healthcare loop. Home medical devices, the smart implants that are being developed, quantified self-data, and now this extremely exciting field of consumer analytics that's now being layered on top of all of this. And an example is just cell phone usage, number of people you call, number of calls you make, and strong associations between a decrease in the number of people you call and a severe slide into depression. So we have data that's being collected already that if we can make associations and weigh those associations, we're going to get to some predictive analytics from data that is very inexpensive, but could actually indicate when someone's heading into a deep slide and get better at managing and maintaining people's wellness than having episodic crisis care where that person ends up in the ER. So these slides you've seen already, I won't repeat them, just to say that the funding in the last 2 years since the last report went out has actually doubled in this space, and it's very exciting. These are the 6 areas that were already defined well. What it says to me, though, is that there's a tremendous amount of excitement and there's a tremendous amount of support that's being put in so far, but we're starting also to mature. And things are getting more serious, and I think this is a good thing. This is one indication of things getting more serious, especially for people who are in the development side of this equation. But I actually think that it's very helpful. And I think it was helpful that they actually released what they're thinking, because investors were holding back knowing that this was coming. And so people now know more definition, not fully, what needs to be put through the FDA process, but it is bringing more scientific rigor, as we know. It's also telling us that this is really serious what we're doing. And if we think these are serious interventions that we're building, then they need to be scrutinized. They need to be looked at, particularly the ones that carry risk for point of care, not just assessment, but care delivery. Imagine the blood pressure cuffs are telling you something, but if you could actually have algorithms that drive changes in your medication that you do at home, there's a huge savings to the system and their improvement in your quality of life. But there is risk in that, and so those types of things need to be evaluated carefully. So I want to talk next where I think we need to think a lot about is getting from promise to power, the promise of digital health to the power of digital health, and ultimately to the empower of digital health. And in this, the promises everyone's heard over and over, the triple aims of better health, better care at lower cost, and getting better care to more people in the highly distributed healthcare model, and the self-management and self-empowerment movement in it. And precision medicine was a big thing for us up at UCSF, where you're you're going to have care, hopefully, that's more targeted specifically to you in a way that you're actually eliminating the toxic effects of your medication if you don't tolerate it well, and the potent, powerful positive effects of it. Shared decision-making, really an important field. So the more information patients and providers have and the more they can communicate with each other, the better that will get. And again, decrease costs over all sectors. So we actually very excitedly thought of digital health not just as the fourth modality. We knew we had diagnostics, therapeutics, device, and then we're adding digital health. In fact, that's how our accelerator was staged. But we actually think of it more as the great communicator. It's actually infusing all of these arenas. So how many people in this room are in digital health technology development? Great. And how many people are involved in healthcare? So you're all involved in digital health technology development. So all of you, the trends that we're talking about are literally infusing everything that you're doing in the work that you do, and of course in your daily lives. So we need to ask some hard questions if we're going to deliver on the promise. We need to find out, do we need more data or do we need right data, and how are we going to figure out what that is? Do these things measure what they say they're measuring? And if they do, and we show that, then are they effective? So we need a lot more evaluation, a theme presented earlier as well. And how are we going to know what this data means? How are we going to take this data and actually contextualize it to make it actionable? Because that's what we really need from all of this, and that's going to be done by interoperability. So in those needs, very quickly, the evaluation piece, it's really important that not just us science geeks and the people who are on the front lines of healthcare or front lines of the medical centers are asking, do these things work? That's sort of reflexive for us to do that scientific rigor experiment. But now other stakeholders are asking, consumers are asking, investors are really asking. I've put in this much. They're coming to us. I get 6 to 10 calls a week saying, does this work? Can you tell me how we're going to find out if this works or not? And payers are also asking, because they're scooping up suites of these technologies and offering them as services and hopefully as preventative medicine for their own clients. So what we need, we have some information. We know that improved patient satisfaction and engagement, which happens with better information, does improve health outcomes. We have good information about that, even to readmission rates. We know that some of the wearable and fitness apps are engaged in, certainly in the short run. We also see a big drop-off rate at 6 months. So sustained engagement hasn't been proven very well. And health outcomes data is truly limited. And for providers and payers, there's plus minus. There's some studies showing good things, other things showing no effect at all. And the cost effectiveness is still way out there to be determined. We so believe in it, but we have to do really good studies to show it. So growing information is in these areas is incentivized, not just from meaningful use, and that actually has driven some very good studies, which I'll show you, but also from the model that we're going to. In ACOs, you are going to need collaboration technologies. You just are going to have them, and they don't exist very broadly right now. But that's the way you're going to really survive and really thrive in a shared risk and shared benefit model. And also in value-based care, we're going to need to have more of these things demonstrated. So looking at the systematic review that was done on meaningful use criteria, which are hard to read across the bottom, but I think most of you are very familiar with them. This does show that there is effectiveness. The green shows that something good happened, and in addition, something bad didn't happen. And each of the other colors escalate in badness. So the red is the badness at the top. It was interesting in e-prescribing, which is right in the middle. That's actually one where there are risks by not following certain criteria. So those e-prescription and all the medication adherence and things that are actually being fed out through pharmacies now really need to be evaluated very carefully, because the bad outcomes can be there. And what we want to do is find out where we can make up efficiencies in the system with technology and automation, but where do we need high touch? We will always need high touch in healthcare, but what we need to do is do a better job of defining where those lines are in specific situations and create efficiencies where we can. So to date, there were also some randomized control studies that have gone on, not a lot. There was a good one with diabetes. This was actually one of the first ones by WellDoc, but that was in 2011. That's how recent it was. And then a really nice overview by Lebrique was done, showing that there are 215 mHealth studies that were registered in clinicaltrials.gov, and these are the different descriptions of each of them, observational versus interventional, et cetera. And 40 new studies were just added since 2011. in May to November of 2012. So people are catching on. There is this transition into the area of evidence-based health, and certainly Scripps has been leading this for some time. But this is an interesting piece of information to look at. There are, so what did we say? There were 200. So there are exponentially more studies done on whether prayer works in healthcare or not. Now, I'm not discounting prayer, and it has been around longer, but it's interesting the amount of money that goes into this per year. This is per year, $5 million on these studies. So, and some from the NIH, mind you. So what we need to do is we need to catch up. We need to catch up with the Spiritual Science Research Foundation, bridging the known and the unknown worlds. Also, the academic medical centers have sort of been leading the way in this, but we need research methodology infused throughout the digital health development community. It's okay, we don't mind, and we actually want you to come to us and ask us, does it work? And we want to help you with the scientific rigor and the study design, et cetera, because we want effective healthcare solutions built. However, it would be great if we could empower you more, because to be honest, evaluation happens about 15 times across the arc of development. It starts with focused interviews. It starts by knowing your audience. That's a form of research. You need to do validation studies. Does it measure what you say it's measuring? Really early on. You need to do engagement studies, sustained engagement. Does it change behavior? Does that behavior affect an outcome? Does that outcome affect a person's health, quality of life, and is it sustained? So multiple steps before you even get to the post-implementation randomized control study. So we want to help with that. So one of the things we're doing is we're putting on a conference this summer. It's the first conference on evaluation in digital health as a methodology. We don't have great methodology. It's very different than our standardized studies, although some of them do apply. But we also don't even have common vocabulary. I would love for a funder to come to a startup entrepreneur and say, what level of effectiveness have you done on this technology? And they could say, well, we've done level 3. And then the funder would say, okay, great, now I know you've done validation, that it's measuring what it says it is, you've done your focus interviews, you've done engagement, sustained engagement, but you haven't really shown it's changing behavior yet. Okay, well, so come back to us when you've shown that. That doesn't exist, I made that up, but to be honest with you, that's the kind of shared vocabulary we're gonna need across these sectors. So we do have resources that exist. I'll point a few out. Certainly you're welcome to come to our websites and we'll have information for you there. But there are also things like the Center for Technology and Aging, which has a great ROI calculator for health implementations in aging populations. Johns Hopkins released a nice website that's a good tool for health evaluation. And then the NIH OBSSR in behavioral sciences has really led the way in effectiveness studies in this area. So if we're going to get promise to power and power plus, which is the M-Power, there's also this thing about data. We want data. We've got data. We're getting more data than we can possibly handle or even make sense of right now. But what we need to do is change that data. We need to get from acquired to actionable, and we need to change that data to right data. So the data needs to be contextualized. It's a really big concept. It's been delivered several times across the panel. It's a very complex problem, but we have to take steps towards that. And this is going to require data aggregation, analytics, algorithms, and an ongoing assessment process. So continued evaluation. And to do that, we have to mind the gap. For all of you who've traveled to London. And that gap is interoperability. And this is a huge problem, and we have had some really nice descriptions of how great it could be and how people are taking early steps. But what is interoperability? This is the HIMSS definition. They've done a beautiful job laying it out. But frankly, it's just this, the ability to exchange and make use of the information. I think that makes a really good comment of why overcomplicate when we can actually just get straight to the message. So inside the clinical care system, we don't have this kind of great connectivity, although you might imagine we do. If you come in and fill out a history form, and I refer you to another specialist, you're going to sit down in an office and fill out the same history form again, and your number of childhood fractures hasn't changed. But that information isn't easily uploaded even to Epic, the legacy systems, and it's not distributed well through the record. So that's just an example of information collected outside the clinical care or in the clinical care setting that doesn't speak to other information, let alone your demographics, et cetera. Also, patient-reported outcomes in clinical research, incredibly valuable data that may never get to your point of care. Your clinical provider may never see the clinical research data that's very robust on you. That may never come into your shared discussion with that physician, although we're making models to do that. So information outside the clinical care loop, a whole list of that data. You can see all the way from the quantified self data, all the way down through even your ambulance record. You come in and you're highly unstable. You've just had these people with you for the last 2 hours. They transport you in. They've got records on carbon sheets of paper, strips of paper EKG that they roll up and tape to the back of your chart. And all of a sudden, they hand your care off, and all of that information doesn't enter into the equation of who's taking care of you next. So also, there's some work been done already. The health information exchanges are a nice attempt, although what's happened is people have pulled off into their sandboxes, Epic's creating their own. Blue Button is a fantastic system, which you should look up if you haven't through the ONC. Continue is a nice attempt. And on the consumer level, there are now cloud-based record storage, image storage, where patients are starting to take control of their own information, which I think is fantastic. So pulling it from disparate sources, having it available to download to the next provider they see. Dashboards of consumer-collected information like Validic, TickTrack, Ginger.io, all very valuable, but they don't get up to the EMR. So I call it sort of the thin layer, and we need to push over including this platform, which is an open source, which is OpenM Health. And I think this would be a nice also resource for people building apps in open health. Standards and operability, key problem being worked on, but why are there still so many missing pieces? Proprietary formats. So many of these devices are in proprietary formats. It's expensive, complex, it requires cooperation, and we've got to align incentives. It should look like this. Stuff outside the clinical record, there's a bridge, it's inside your clinical record, it flows back and forth. But just like the cell wall, it's incredibly complex. Back to the science geeks again. Information has to come in. It comes in different formats, need different receptors. It's got to be acted on once it's inside. And before you ever get anything actionable out of what came through that cell wall, many, many processes have to happen. So actually, it looks much more like this, which is really what the platform will look like. We think of it like this. All that information should easily come to your doctor gives you a response, but these are all the different layers it's going to take to make that happen. So we also think for a next step that we need more people from the front lines of healthcare and the front lines of life sciences and the front lines of the academic medical centers to be involved in this. We think that we have unique places where we serve a role in conceptualizing the problems or identifying the problems, like the therapeutic targets we used to talk about in drug development. We experience the pain points. We witness the pain points in our patients. We can conceptualize solutions that fit into the process or workflow, or where that workflow needs to be disrupted. And then we swim in our own soup. We have to use what we're building. And we also have to build solutions for now and solutions to where things are going, the new models that are coming. So we think we have a really important role to play, but good gosh, we don't know half of the stuff in the middle to get across the arc of development. So we really need to partner with all the different sectors to get across there, and we need to do evaluation all the way across. We think evaluation is another strength of people on the front lines. These are examples of things that have already been built. I think what I'll do is, I was going to talk a little bit about our own center, but I'll just skip to this slide and then close. In our own model, by identifying where we thought we had strengths and weaknesses, we put together the Center for Digital Health Innovation with 4 pillars. Innovation, and we support our frontlines innovators. And we're trying to make that a much more robust process. We do have accelerators, incubators, et cetera, but we're providing more virtual resource center to them. And then validation, very importantly, offering validation services to inside and outside technologies that are being built. Integration is the interoperability platform I talked about. And education, finally. We think it's really important that we're not just building technologies from the front lines, but we're building problem solvers. So education internally and externally for the digital health ecosystem is something that we provide as well. I think my time is up, so I'll stop there.
Thank you so much.